Hey there, if you're a nursing student staring down the barrel of your pediatric exams right now, or maybe you're gearing up for the NCLEX, I see you. I know the stress is incredibly real. Chapter 24, the child with a musculoskeletal condition, is dense, it's complex, and it is heavily tested. But don't worry, because in this explainer, we're going to just slice right through the noise. We're doing an ultra-focused, high-yield crash course straight from the source material. No fluff, just the absolutely critical facts you need to understand the concepts and completely ace those questions.
All right, let's look at our agenda for today. We have 5 main areas to tackle. Kids' bones are different, fractures and traction rules, neurovascular checks and emergencies, spotting child abuse, and finally, high-yield pediatric diseases. Let's get to it.
Section 1. Kids' bones are different. We're putting on our anatomist hat for this one.
So, understanding this baseline anatomy is basically the foundation of pediatric nursing. You really have to remember that a child's skeletal system is not just a miniature adult system. Adult bones are fully ossified, meaning they're completely hardened, and well, when they break, they heal pretty slowly. But pediatric bones, they are still actively growing. They have these cartilaginous epiphyseal plates, you probably know them as growth plates, right at the ends of long bones. On top of that, their periosteum, which is the tissue covering the bone, is much thicker and highly active. That thicker periosteum means a child's fracture is going to heal much more rapidly than an adult's. But here's the catch. Any injury to that epiphyseal plate is a massive red flag. If that plate fractures, it can actually disrupt the longitudinal growth of that bone, literally permanently altering the child's physical development.
Now, because of that epiphysis and something called hyperhemia, which is basically the increased blood flow that happens after a trauma, bone overgrowth is actually super common in healing fractures for kids under 10 years old. In fact, getting exact perfect alignment of a fracture during a reduction isn't always absolutely necessary in these younger kids. Why? Because that accelerated growth in bone remodeling just naturally happens for 6 months to a year following the injury. The body literally corrects itself. It's kind of amazing.
Section 2. Fractures and traction rules. Time to switch over to our caregiver hat.
Sometimes mechanical help is needed to align bones, right? That's where traction comes in, using pulleys and ropes to apply combined forces. Now listen closely, because here is your cardinal, totally non-negotiable NCLEX safety alert. The weights must hang freely. Period. They are there to provide continuous countertraction. As a nurse, you must never, ever lift or remove those weights while you're delivering patient care. If those weights accidentally hit the floor or get rested on a chair, the traction is broken. The bone fragments can immediately shift, and your patient is going to be in severe, awful pain.
So let's quickly lock in this vital nursing checklist for any traction apparatus. First, the child's body must be in proper alignment. Second, as we just hammered home, those weights must hang freely. Third, keep the weights completely out of reach of the child. Kids are curious, you know. They will definitely play with them if they can reach them. Also, make sure the ropes are actually sitting right in the wheel grooves of the pulleys, that the knots aren't jammed up against the pulleys, blocking the pull, and ensure bed linens aren't resting on the ropes, because that actually changes the tension. Keep in mind, any deviation from this checklist in an exam question is a distractor, or, in real clinical practice, it's an error you've got to fix right away.
All right, time for our first knowledge checkpoint straight from the review section. Let's test that clinical judgment. A teenager who had a cast applied after a tibia fracture complains that pain medication is not working at all, and his pain is a 9 out of 10. The nurse notices edema of the toes and a capillary refill of 6 seconds. So what is the priority nursing action here?
The answer? You call the healthcare provider immediately. You don't wait around asking for a stronger pain meds, and you definitely don't try teaching non-pharmacological breathing techniques. Pain that is completely unrelieved by medication, especially when it's combined with swelling and a horribly slow capillary refill of 6 seconds, is a giant flashing red flag. This points directly to our next big topic, compartment syndrome. It's a true medical emergency that requires rapid intervention if you want to save the limb.
Section 3. Neurovascular checks and emergencies. Let's put on the detective hat for a minute.
Spotting subtle clinical clues isn't just about passing a multiple-choice test. It's literally about saving a child's limb. To be a good detective here, you need a systematic approach. This is your frequent neurovascular check, designed to ensure the tissues are getting adequate blood flow. Step 1. Assess pain location and quality. Step 2. Check the pulse, and always compare it to the strong, unaffected extremity. Step 3. Check sensation. Any reduced feeling or tingling distal to the fracture is bad news. Step 4. Look at the color. Pallor means arterial insufficiency, while cyanosis means venous pooling. Step 5. Check capillary refill. And finally, Step 6.
Test movement of the fingers or toes distal to the injury because nerve damage can quickly compromise motor function.
So why are we doing these checks so obsessively around the clock? Basically, to catch compartment syndrome before it's too late. The text defines this as a progressive loss of tissue perfusion caused by an increase in pressure from edema or swelling that compresses the vessels and tissues. Circulation just gets entirely compromised. And honestly, often the only fix at that point is a surgical intervention called a fasciotomy. That's where they literally cut into the tissue to relieve the pressure and restore that vital blood flow.
Think about testing that capillary refill. You squeeze or press a toe or finger to blanch the skin. If circulation is doing its job, that healthy pink color should bounce back in less than 3 seconds when you let go. But if the toes don't blanch at all, congestion is present. If that blanching persists beyond 3 seconds, or if the patient experiences extreme out-of-proportion pain from you simply touching or moving their toes, you report it to the provider immediately, no hesitating. Section 4. Spotting child abuse. This is where we shift into the defender role, and it's a heavy one.
Now, what's incredibly important to grasp here is exactly how injury patterns tell a story. Let's consider a spiral fracture. The femur is the largest, strongest bone in the whole body. A spiral fracture happens when a really forceful manual twisting motion is applied to the limb. If you see this in an infant who isn't even ambulatory yet, meaning a baby who literally cannot walk, it is an immediate, glaring red flag for child abuse. The history of the injury provided by the caregiver simply is not going to correlate with the X-ray findings of a forceful twist. As a nurse, you are legally mandated to refer this to an assessment team.
Another vital tool for you as a defender is understanding the stages of bruise healing. The text actually highlights this as a major safety alert. Bruises change color in a very predictable way. They are swollen and tender for the first couple of days, turning red or purple by day 5, green by day 7, yellow by day 10, brown up to day 14, and clearing up entirely by about 4 weeks. So why does this timeline matter so much? Because you must constantly be asking yourself, does the color of this bruise actually match the caregiver's explanation of when and how this injury happened? If a parent says the child fell off the couch yesterday, but the bruise is distinctly yellow, those stories do not align.
Let's lock this knowledge in with another quick checkpoint. A type of fracture in a young child that may be indicative of child abuse is 1. Green stick, 2. Spiral, 3. Pathological, or 4. Aligned.
If you guessed a spiral fracture, you hit the nail on the head. Specifically, a spiral fracture of the femur or humerus in a non-ambulatory child is highly suspicious because it requires that violent twisting force we talked about. Green stick fractures, on the other hand, well, those are incomplete breaks that are just super common in normal childhood accidents because kids' bones are so flexible. But spiral fractures, those mandate a much deeper investigation.
Section 5. High-yield pediatric diseases. Time for our final role, the diagnostician. Okay, we're going to do a rapid-fire rundown of the absolute most testable pediatric musculoskeletal diseases. Think of this as your high-yield cheat sheet. First up, Duchenne's muscular dystrophy. It's a progressive disease primarily seen in boys. The classic, highly testable sign here is Gower's maneuver, which is this characteristic way the child uses their hands to literally walk up their own legs to rise from the floor because of severe pelvic weakness. Treatment for this is heavily supportive to prevent contractures. Next is osteomyelitis. This is a really severe bone infection. Key signs are localized pain and elevated inflammatory markers like WBC and ESR. The nursing action you absolutely must know. It requires a strict, long-term regimen of intravenous antimicrobials, usually lasting for 4 to 6 weeks. Finally, scoliosis. The key sign is an S-shaped curve of the spine along with asymmetrical shoulders. The major nursing intervention here is ensuring routine screening happens before middle school so we can catch it early. Let's test that rapid-fire knowledge with one final practice checkpoint. An abnormal S-shaped curvature of the spine seen in school-aged children is? Yep, the answer is scoliosis, and the rationale for why we screen for this so aggressively in prepubescent kids is crucial to understand. Most curvatures aren't progressive, sure, but if severe scoliosis is left untreated, it can eventually restrict lung function and even impair the heart due to the skeletal deterioration. Early bracing or surgery can literally prevent those life-threatening complications. As we wrap up today, I want to bring the emotional and professional gravity back to your holistic role as a nurse. The source text includes this really profound insight. The nurse must acknowledge that there are always two victims in cases of child abuse, the child and the abuser.
It reminds us that abusers often have deep psychological deficits themselves. They might be under overwhelming stress, or maybe they are horribly abused themselves. Removing the child from the situation is definitely one answer, but real healing requires understanding that tragic cycle. It's a heavy burden for sure, but empathy is a massive part of the job description.
Well, we've covered a ton of ground today, from the fast-healing periosteum of a toddler to the strict, unbreakable rules of hanging traction weights, all the way down to identifying the grim, subtle signs of abuse. So as you close your books and eventually step onto the hospital floor, I want to leave you with this thought. Beyond just passing your exam, will you be the detective who spots the subtle clues of a neurovascular emergency or a mismatched bruise before it's too late? Your knowledge won't just earn you a license, it's literally going to save lives. Thanks so much for learning with me today. Keep studying, stay focused, and I'll catch you in the next explainer.